Okay, so today we're doing a deep dive into some pretty major respiratory conditions.
Yeah, sounds like a plan.
Asthma, tuberculosis, which most people probably know as TB, and then COPD, which stands for chronic obstructive pulmonary disease.
Right, big ones.
Yeah, definitely. And I think what we're aiming for here is, like, how do we pull out the most important stuff about each of these, from all this information we've got here? Looks like mainly medical and informational documents, stuff like that.
Yeah.
So we can kind of give people a good understanding of, what they are, what to watch out for, all that, without, overwhelming them with all the medical jargon.
Right, cut to the chase.
Exactly. So let's just jump right in. Asthma. What exactly are we talking about when we say asthma?
Well, the way these sources lay it out, it basically comes down to inflammation, chronic inflammation, and it's specifically in the airways.
Okay, so like not just a random cough, but something going on deeper in the actual tubes that carry the air in and out.
Exactly. And the thing that really makes asthma is this thing called airway hyperresponsiveness. It's almost like the airways are super sensitive.
Oh, interesting.
They react to things that wouldn't bother most people's lungs, and that's what leads to all that, the trouble breathing, coughing, that wheezing sound.
Yeah, okay, that makes sense. But it's not just one thing that sets it off, is it? Looking at all this, there's a whole bunch of triggers.
Oh, yeah, for sure.
So we've got the obvious ones, like everyone knows about allergen.
Right, pollen and dust and all that.
But then it can also be things like, exercising or even just cold air.
Yep.
And here's something that might surprise people. Medications. Like some medications can actually be a trigger for asthma.
Oh, yeah, absolutely.
And the sources actually list some specifics. They mention salicylates, so that includes aspirin, and then NSAIDs like ibuprofen, things like that.
Very common.
Right, exactly. And then there's also things like cholinergic drugs and even beta-adrenergic blocking drugs.
Right, and I think that's something people should really pay attention to, if you've got asthma or if you know someone who does, that those seemingly random medications could actually set off an attack.
Yeah, that's really good to know.
It's a big part of managing the condition.
So it's not just what you breathe in, it's other things too.
It can be all sorts of stuff. Like they even list things like chemicals, smoke, obviously, and, this is one we might not think about as much, strong emotions.
Oh, interesting.
So anxiety, stress, that can actually play a role.
That's wild. It really shows how connected everything is, your mind and body.
Absolutely.
Especially with something like asthma.
Yeah. I mean, we think of it as a lung thing, but it's more complex than that.
Right. Okay, so let's talk about what happens when things get really bad. Like when someone's having a full-blown severe asthma attack. What does that even look like?
Well, according to this, it can get pretty scary.
Yeah, I bet.
We're talking about that feeling of not being able to breathe.
Like suffocating.
Yeah, like suffocating. And then there's chest pressure, a cough that doesn't bring anything up, and of course the wheezing gets really bad.
So it's more than just feeling a little short of breath. It's like...
It's serious.
Yeah, serious.
Their body's really struggling to get oxygen.
Right.
And a big giveaway is if they can't even finish a sentence in one breath.
Wow.
Think about it. We use so much air just talking.
That's true. I never thought of it like that.
So if you can't even get a few words out, that shows how bad it is. And they also point out that sometimes those inhalers, the quick relief ones, they might not even work during a really bad attack.
Oh, wow. So it's like...
It's beyond that. And then physically, you might see their blood pressure go up, their heart's racing. That's called tachycardia, by the way.
Oh, all right.
And they might be sweating a lot, like really sweating.
So the body's like freaking out.
Yeah, it's in panic mode, basically.
Wow.
And in the worst cases, they say you might even see stringy mucus and even cyanosis, which is like a bluish color on the skin.
Okay, so that's really serious.
Oh, yeah. That's when you know it's really bad. And they need help, like right away.
So say you see someone having an attack like this. What do you do? What are the first things you should do?
First things first, help them sit upright. That's the best position to open up their airways.
Okay, makes sense.
And then you want to get them using their beta-2 agonist, like salbutamol. Like, a lot of people know it by the brand name, but yeah, salbutamol.
Right, the rescue inhaler.
Exactly. For adults, it's 2 puffs, deep puffs, and for kids, just 1. And you can repeat that up to 2 more times, like every 5 minutes, if the attack's still going.
Okay, so those first few puffs are super important.
They can make a huge difference.
But what if it doesn't work? What if they're still struggling after those first 3 tries?
Then it's time to get more serious.
Like call an ambulance.
Definitely. Call 911 or whatever your local emergency number is.
Okay.
But also, for adults, they might need epinephrine, the 1.1 thousand, are kind of usually given as a shot, like into the muscle. The dose is beyond zero point 0.3 to zero point 0.5 milligrams. For kids, it's less, 0.01 milligrams per kilogram of their weight. And that can be repeated every 5 to 10 minutes if they need it.
Okay, so that's definitely something paramedics would do. Right.
Right.
But what if the ambulance is delayed?
Well, if that happens, there are a couple of other things they might do. They could give theophylline intravenously, slowly, over like 10 minutes. The dose is 250 to 500 milligrams. And they could also give hydrocortisone sodium succinate, also intravenously at 100 milligrams. But again, these are things that would be done in a hospital setting.
Right, not something you do at home.
Exactly.
Okay, so now let's shift gears a bit and talk about, day-to-day life with asthma. Like, what can people do to prevent these attacks from happening in the first place?
Well, there's a lot to consider, actually.
Yeah, it's not just about having the inhaler on hand.
No, it's more than that. Like, something as simple as when you schedule your appointments can matter. They suggest late morning or late afternoon for people with asthma.
Oh, interesting. Is that because of the pollen count or something like that?
Could be. Some people have worse symptoms at certain times.
Good to know.
And then, of course, there's the medication. Taking your inhalers exactly as your doctor prescribed them is super important.
Right, not just when you feel like it.
Nope, gotta be consistent.
Okay, and speaking of feeling things, I noticed they mentioned stress management in here too.
Oh, yeah, that's huge. Like, just going to the doctor can be stressful, right?
Definitely.
And for some people, that stress can trigger an attack.
Wow, so it's like a vicious cycle.
Kind of. So
Yeah.
they talk about things like sedation, oral or even intravenous in some cases to help people relax.
Right, so they can get the care they need without,
Without freaking out and making things worse.
Exactly.
And of course, always, always having your rescue inhaler with you.
Can't stress that enough.
Never leave home without it.
Right. And what if someone's asthma just doesn't seem to be under control? They're still having attacks or their symptoms just won't go away.
Then they need to talk to their doctor.
Yeah, don't just tough it out.
No, definitely not. There might be things they can adjust in their treatment plan.
Right, like different medications or something.
Could be. They also mention anxiolytic drugs and sedatives being used sometimes.
So addressing that anxiety piece.
Yeah, it's all connected.
Okay, so it sounds like there's a lot you can do to manage asthma, but are there things you should definitely not do? Are there any no-nos?
Oh, yeah. There are a few big ones they really emphasize.
Okay, let's hear them.
First off, aspirin. They say aspirin is a no-go for anyone with asthma.
Even if it's mild.
Even if it's mild.
Wow, okay. What else?
NSAIDs. So those are the non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, things like that.
Right.
If you have active asthma, meaning you're taking meds regularly, you got to avoid those.
Got it. Anything else?
One more. Morphine and meperidine. Those are types of opioid pain medications.
Okay.
And they can also trigger attacks in some people.
So it's not just about what you breathe in, it's what you ingest, too.
Exactly. Asthma's a tricky one.
Okay, good to know. Let's move on to our second condition, tuberculosis, or TB. Can you give us a quick rundown for those of us who might not know much about it?
So TB is caused by a bacteria, this specific one called Mycobacterium tuberculosis.
Okay, so it's an infection.
It is, and it's contagious.
Right, you can catch it from someone else.
Exactly. You get it by breathing in these tiny droplets, like if someone with TB coughs or sneezes.
Okay, yeah, that's how a lot of respiratory stuff spreads, right?
Mm-hmm. Now, the thing about TB is it can be kind of sneaky.
What do you mean?
Well, it has this latent period.
Latent,
Like inactive. The bacteria can hang out in your body for a long time without making you sick.
Really? So you could have it and not even know it?
Exactly. But if the bacteria start to multiply, then things change.
That's when you get sick.
Yeah, your body tries to fight it off, and that's when you start having the symptoms of active TB.
Okay, so how do doctors know if someone's gone from that latent stage to, actually being sick with TB?
Well, there are a few things they look for. One is something called a positive acid-fast bacillus sputum smear. Sounds complicated, but basically it means they can see the bacteria in a sample of your sputum, the stuff you cough up. And then, of course, there are the symptoms, the cough, fever, weight loss, night sweats.
So pretty general stuff, but if it all comes together.
It raises a red flag, for sure.
And they also use chest x-rays, right?
Oh, yeah, that's a big one. They can see certain changes that are typical of TB.
Okay, so if all those things point to TB, how do they actually confirm it? 100% sure it's TB.
The gold standard is actually finding the bacteria itself. They do that by taking a sample, usually sputum, and trying to grow it in a lab.
Kind of like those Petri dishes you see in movies.
Exactly. They call that culturing. Or they can do these molecular tests that look for the bacteria's DNA.
Okay, high-tech stuff.
Yeah, very precise. And they usually like to get 3 sputum samples taken on different mornings.
So more samples, more accurate.
Exactly. They want to make sure they don't miss it.
Now, because TB is contagious, that makes things tricky in healthcare settings, right? Like, what if someone with TB needs dental work?
Yeah, they're pretty clear about that in the guidelines. If someone's just been diagnosed and they're still infectious, meaning they're coughing up bacteria, they should be treated in a hospital.
Okay, so like, not your regular dentist's office.
Nope. They have a special rooms for that with like negative pressure and all that to keep the bacteria from spreading.
Right, makes sense. So when would it be okay for someone with TB to get regular dental work?
Only after their doctor says they're not contagious anymore.
So after they've been on medication for a while.
Yeah, and their tests are negative. It's all about protecting everyone involved.
Makes sense. What about those chest x-rays? What are the doctors looking for that screams TB?
Well, they might see these patchy areas or nodules where there's inflammation. Often it's in specific parts of the lungs, like the upper lobes, or sometimes in the middle or lower lobes. And if it's really active TB, they might see cavities, like actual holes in the lung tissue.
Wow, that sounds scary.
Yeah, it can be. And also swollen lymph nodes, especially in the area where the airways and blood vessels enter the lungs. They call that the hilum.
Okay, good to know. So that's TB in a nutshell. Now, our last condition, COPD. And I know this isn't just one thing, right?
You got it. COPD is like an umbrella term.
Okay, so explain that.
It covers a bunch of lung problems that all have this one thing in common. The airflow in your lungs is limited and it doesn't get better, not completely.
So it's chronic, like long-term.
Yeah, exactly. And the 2 main ones they talk about are chronic bronchitis and emphysema.
Okay, so 2 different conditions, but both under the COPD umbrella.
Right. It's like they're related, but not the same.
Okay, so let's break it down. What is chronic bronchitis exactly?
Well, it all starts with inflammation, but this time it's in the bronchi. Those are the bigger airways in your lungs.
Okay.
And that inflammation makes them produce way too much mucus.
Ugh, that sounds unpleasant.
It is. The main symptom is a cough, but it's not just any cough. It's a cough that produces phlegm.
So a productive cough.
Yeah, that's the medical term for it.
Okay.
And to be diagnosed with chronic bronchitis, you have to have this cough for at least 3 months out of the year, for at least 2 years in a row.
So not just a random cold or something.
Nope, this is chronic. It keeps coming back.
Got it. And then there's emphysema. How's that different?
Emphysema is more about the structure of the lungs. Those tiny air sacs in your lungs, the alveoli, they get all stretched out and damaged.
So they're not working properly.
Exactly. They lose their elasticity, so it's hard to get air out.
So with bronchitis, it's more about the mucus, and with emphysema, it's more about the, like, actual structure of the lungs.
You got it. They both mess with your breathing, but in different ways.
Makes sense.
Yeah.
So how do they figure out if someone has COPD, considering it can be either of these things?
They look at a bunch of things. Your medical history, first of all, like have you smoked? Do you have trouble exercising? And then they'll listen to your lungs, see if you're coughing, producing phlegm, and if you get short of breath easily.
So pretty basic stuff.
Yeah, but it tells them a lot. They'll also do some tests like spirometry, which measures your lung function, and they might check your blood gases to see how well your lungs are oxygenating your blood.
Okay, and what about imaging, like x-rays or CT scans?
Yeah, those can be helpful too. They might see changes in your airways, or your lungs might look hyperinflated, meaning they're kind of overexpanded.
Okay, so it's a whole bunch of clues that come together to make the diagnosis.
Exactly.
Now, I read something about blue bloaters and pink puffers. What are those all about?
Yeah, those are old terms.
Like old school diagnoses.
Kind of. Blue bloaters were people who mainly had chronic bronchitis.
Okay.
And they were blue because they weren't getting enough oxygen, so their skin would have a bluish tint.
Ah, that makes sense.
And they were bloaters because they often had swelling, especially in their legs, which could be from heart problems that come with having bad lungs for a long time. They usually had a lot of mucus, a bad cough, and they were often like overweight and not very active.
Okay, and what about pink puffers?
They were usually the emphysema folks. They were pink because their oxygen levels were usually, okay, so no blue tint. And they were puffers because they did this pursed lip breathing thing.
Like to try and force the air out.
Yeah, it helped keep their airways open. They were usually thin, had a barrel chest because their lungs were overinflated, and they didn't cough as much or have as much mucus.
So kind of opposite to the blue bloaters in a lot of ways.
Yeah, pretty much. But the thing is, these days, they say most people don't fit neatly into those
So
categories.
it's more of a spectrum.
Exactly. Most people with COPD have a mix of bronchitis and emphysema, so it's not so clear-cut.
Okay, good to know. Now, when it comes to treating people with COPD, are there special things doctors and dentists need to keep in mind?
Oh, yeah, definitely. Like, positioning is important. They say you should never have them lie flat on their back.
Oh, really? Why not?
It makes it much harder for them to breathe.
Ah, that makes sense.
So they recommend a semi-reclined position, or even sitting upright in a chair.
Okay, so being mindful of their breathing the whole time.
Absolutely. And you really got to check how they're doing before you start any treatment. If they're short of breath, even at rest, or they have a cough or any signs of an infection, or if their oxygen level is low, you should reschedule.
So basically, don't do anything if they're not breathing well.
Pretty much. And if their COPD seems really out of control, like they're having lots of problems, you need to talk to their regular doctor before doing anything.
So communication is key.
Always. And with really severe COPD, they say you should probably avoid any elective treatments, things that aren't absolutely necessary.
Okay, so prioritize the essentials.
Exactly. And then there are some medications to be careful with. Opioids, those strong painkillers, they can make breathing worse, so you have to use them very cautiously.
Right, and what about laughing gas? I know they
Ah.
use that a lot in dentistry.
Yeah, nitrous oxide. They say that's usually not a good idea for people with COPD.
Okay, so what do they use instead for anxiety?
They might give a low dose of diazepam or another benzodiazepine, but they have to watch them really carefully.
So lots to think about with COPD.
Yeah, it's a complicated one.
Okay, well, this has been a really in-depth look at asthma, TB, and COPD.
Yeah, we covered a lot.
We talked about what each condition is, what triggers them, how to recognize when something's seriously wrong, and all the things you need to keep in mind for managing them long term.
It's amazing, isn't it, how these three conditions, they all affect breathing, but in totally different ways.
Yeah, it's like they're all attacking the same system, but from different angles.
Right, like asthma is all about inflammation and sensitive airways, TB is a sneaky bacterial infection, and COPD is about damage to the actual structure of the lungs.
Yeah, they all make it hard to do that one basic thing, breathe.
Exactly. It really makes you appreciate how important healthy lungs are.
It does, and I think the takeaway for everyone listening is pay attention to your breathing. If something feels off, even a little, don't ignore it.
Yeah, it could be nothing, but it could be a sign of something more serious.
Right, better safe than sorry.
Always.
So if you have any questions or concerns, do some research, talk to your doctor, be proactive about your health. Thanks for joining us for this deep dive. We'll be back soon with another one.
Looking forward to it.